Just wait it. Starting your 2 minutes time. Started your timing. Hello, Dr. Reshma, I have started your timing.
Hi, I'm Dr. Reshma, one of the doctors in the antenatal clinic today. May I confirm your name and age?
Yeah, I'm Stacy. I'm 21-year-old doctor.
Is it okay if I call you Stacy?
Yeah, it's okay, doctor.
Stacy, the midwife has asked me to see you, and she told me that you are 36 weeks into your pregnancy, and you are having some concerns regarding the mode of delivery, and you are here to discuss with me. Is that right?
Yeah.
Okay, Stacy, is it okay if I ask some more questions about your pregnancy and yourself? So
Yeah,
then
that's
we will reach a safe and mutually agreeable plan.
okay.
Stacy, can you tell me more about your concerns?
I have seen this tears and I have seen this babies being died. So I am very strongly wanting cesarean section, doctor.
Stacy, I understand. So sorry to hear that. Uh, Stacy, can you tell me more about your pregnancy?
This is actually unplanned pregnancy, but then I decided, I and my boyfriend decided to discontinue the pregnancy. So far as everything is normal, my last scan was done at 28 weeks, and that was also normal. Everything is normal so far as doctor, including my baby's blood birth weight. That is also something normally. The recent scan, which was done actually 2 weeks back, it's showing 2.6, something like that. So normal, everything is normal. All my blood test, everything is normal. My baby is moving normal.
Oh, okay, Stacy, that is good. That is good. Stacy, do you have any other medical problems during pregnancy, like any diabetes, hypertension, anything?
No.
Okay, Stacy. If you allow me, I would like to go through your reports and your scan reports. Is that okay?
Okay. Yeah.
Are you on any medications apart from the pregnancy vitamins?
No, doctor, I'm not on any medication.
Okay. Okay, Stacy, do you see your GP for any other concern?
No.
Do you have any history of surgery on your tummy or down below?
No.
Okay. Do you have any allergies to drug?
No,
Any family history of concern? Do you know your weight to height ratio?
it's normal.
Okay. May I know your blood group?
It's I think A positive.
Do you have any reservation for blood transfusion?
No,
Okay, Stacy, what do you do for a living?
I'm a nursery assistant doctor. It has been mentioned.
Oh, okay, okay. How's the support at home?
Yeah, I'm being in relationship since last 6 months. Six means few months only. I'm being in a new relationship before getting pregnant. Yeah, my partner is supportive.
Oh, okay. Stacy, do you smoke or drink alcohol?
Oh yeah, I used to smoke a lot. Now I have cut it down. I'm on the verge of quitting it.
Okay, that is very good. It is very good if you quit smoking. That will be very good for your baby and for your general health. Stacy, may I know your future pregnancy plans? Are you planning for any other kids in future?
No, no, yeah, I do want to have two more babies.
Oh, okay. Okay, Stacy, if you allow me, I would like to examine you in presence of a chaperone. My
Mm,
nurse will take your heart rate, blood pressure, and I would like to examine your tummy and to see your baby's heartbeat. Is that okay for you?
it's okay, doctor.
Okay, Stacy, I understand your anxiety and concerns well. But whatever decision you take, we will be supporting you. Your pregnancy and delivery will be managed by a team of doctors, including my consultant, the specialist nurse and midwife, the sleep doctor and baby doctor will be involved in that. Stacey, I appreciate your choice of planned cesarean section as it has got many good things with that. If you are planning for a cesarean section, if everything goes well, there won't be any rush at that time. You can uh, shortcut the prolonged process of labor pains, everything. But I have got some concern regarding that. Is it okay? I discuss that with you.
Okay.
Stacy, when we are thinking about cesarean section, as it is a major surgery, it comes with the complications for all, like any other surgeries.
Hmm.
Like you can have some complications because of the sleep medicines that you will be given at the time of surgery. And so after the cesarean section, you will have a cut on your lower tummy. And there is chance of injury to the surrounding structures, like they can have an injury to your bladder and maybe your bowel at the time of surgery.
Hmm.
And this cesarean section, it will take some more time for the recovery compared to a normal vaginal delivery. And you may need to be in the hospital for some more time.
Hmm.
Are you with me?
Yes.
And it may take a little more time for you to start breastfeeding compared to vaginal delivery.
Okay.
Okay, then when we are thinking of the long-term complications, as you like to have two more kids, if
Hmm.
you a cesarean section at this time, maybe you have to go for. Sometimes there is more chance that you need cesarean sections in your future pregnancies also. And another complication is that there can be some problem with the afterbirth, and the afterbirth can invade into the scar which is occurring this time. And if the bleeding is some bleeding occurs and if it is uncontrolled, and there is a chance that you may lose your womb at that time. That is, even though it is a rare situation, there is a chance. Are you with me, Stacy?
Okay.
So regarding vaginal delivery, as you know, it is a natural birth process. It has got a short recovery period, and you may need a short hospital stay, and you can return to your activities faster compared to cesarean section.
Hmm.
And if you have concerns about vaginal delivery, if you're preferring vaginal delivery, you will be given one-to-one support during your delivery, and you will be given adequate pain medications. For that, the sleep doctor will talk to you, and you won't be alone going through the process. You will be well supported, and we all are here to support you during the
I'm
process.
not worried about pain, doctor. I'm worried about the tear which has happened to back passage and actually my boobs. friend also had a very traumatic birth. They had applied this forceps and the baby was in an ICU for a long time. So those are the problems. So can you guarantee me that that will not happen in my case?
I understand your concerns, Stacy. Actually, no one can guarantee that you won't have a tear at the time of delivery. There is a possibility that if there is some complication occurs, an instrumental delivery may be needed at that time. So there can have a tear at that time. And if it is a complicated one, you can have some problem with your bowel work in the future. And I cannot
I don't
guarantee
want.
that even if
Yeah, I don't want to take a risk along with that doctor. So then I will be going ahead with C-section, doctor.
so, Stacey, I can give you some patient. Actually, I'm giving all this information because you can take an informed decision. And I can give you some information leaflets regarding both vaginal delivery and cesarean section. And you can go through that and you can discuss with your partner and family members. And you can come back to me and my consultant. I will also connect you to my consultant, and you will have better information from my consultant. And then you can take a decision. And whatever decision you take, we are here to support you. Is it okay,
Thank you.
Stacey?
Yeah, thank you.
Okay, Stacey, then I will take an appointment with my consultant in 1 week time, and you can go through all these leaflets and you can come back to us.
Yeah,
Okay,
thank
Stacey.
you. Thank you.
Thank you. Thank you for talking to me today.
Okay, so last few seconds, 40 seconds has been left. Okay. So what do you think about your task? Do you means were you successful in convincing me regarding the vaginal birth?
No.
Yeah. So then that is something which we have to communicate with a positive affirmation. Yes, there are the risks associated with vaginal birth, which no one can uh, means no one can deny that there are no risk, but the risk can be minimized. How you are going to minimize those risks, that you have to emphasize, dear.
Okay, ma'am.
Okay. The
Okay.
risk of tear is there, the risk of instrumentation is there, but we can minimize the risk of tear by going doing the perineal massage from 32 to 34 weeks onward, pelvic floor muscle exercises, keeping the perineum warm and giving episiotomy if at all we are going to go ahead with the delivery. Okay, and that too especially instrumental delivery. Instrumental delivery, most of the time, if it is a spontaneous labor started spontaneously in a normal built lady with an average built baby, they will be delivering successfully. Yes or no?
Oh, yes.
Okay. What are the maximum possibility of her? What are the maximum possibility? You have to see here the maximum possibility. Yes, there is a risk of instrumentation, but is it maximum 1 in 7 or 1 in 15? What is that? 1 in 13%. No? The instrumental delivery incidence is 13%, no? 13 to 15%. Yes.
Yes, ma'am.
So that means there is a very good chances that she will be delivering vaginally without intervening with and she is an absolute low risk baby. So that convincing power you need to bring while consulting this patient, and then only she will be agreeing for the vaginal birth. Although, yes, you have to say that it's her choice. She can choose what suits best for her, but you are there to discuss the options. That you have to emphasize on that autonomy. You have to
Okay.
emphasize on autonomy also, but then you have to guide her that the vaginal birth is an option where the possible complications are very minimal if it is successful. And in her case, since she is a absolute low risk patient, the chances of complication is very minimal. The chances of favorable outcome is very high as compared to adverse outcome.
Okay, ma'am.
Yes.
Okay.
Okay. Yeah. So anybody would like to have anything comment on that? And in the beginning, why you offer MDT to all the patients? She's an absolute low risk patient. So still you want to involve your consultant, neonatologist, pain doctor. What do you think if she is a low risk patient? What do you where she will be delivering?
In the
Only apart
midwife,
from the smoking, the history, most of the history is absolutely low risk patient. So do not involve everyone from the very beginning. Okay, do not
Sure.
means assess what kind of patient she is, and depending upon that only you are going to involve. Anybody is having any comments or feedback for her? Shall I go ahead with the discussion? Okay, so
Uh,
my yes, dear. Yes,
Ma'am,
dear. Hmm?
if the previous tear is with third or fourth degree, then she will become a high risk patient, right, ma'am?
Then actually the risk of having tear will be very high. So that also you have to, then in that case, you have to counsel for both vaginal delivery and cesarean section.
Cesarean.
Yeah,
Okay.
yeah, that is a non-directional counseling because there is a risk of repeat tear, which is 5 to 7%. So then that case, you have to counsel for both, and you have to there also you cannot say that it will be direct cesarean section. You have to tell her
Okay.
efforts, what efforts you are going to take to minimize that tear. Okay, no
Okay.
direct section in those cases. Okay. So my
Okay.
information gathering here is how is her pregnancy, corresponding, non-corresponding, DFKC, baby moving or not moving, okay? ANC case details, how the baby's movements, okay? That DFKC basically means how's the baby movement. When was last USG and future fertility wishes, okay? And you appreciated my view, and why also you acknowledge my fear also, okay? If it is possible, you can address one by one. How's the patient? How is your friend's baby now? You can ask that also just to show some sympathy. Medical, surgical, allergy, smoking. She is on the verge of quitting it, so we can emphasize good what she is doing. uh, Emphasize on stopping completely is always better off. Alcohol, drug history per se, you can ask, you can skip support and domestic violence history because she's just 21-year-old. BMI, which is okay, relevant history. Uh, Hypertension, you had asked a history of hypertension, which is not, which is a jargon, avoid jargon, okay? Examination not needed in this case. You can just, because the patient had just come to you with a for counseling, so whenever there is a counseling task, report discussion task, examination is not needed. In emergency task, yes, you can examine the patient, but in this case, no. Explain her pregnancy, that it's a low risk pregnancy and having a least probably possible complications like tear, requiring instrumental delivery, prolonged labor, because the baby is average size, not small, it is an average size baby what she's having. And you can anticipate that the baby, pregnant baby, may go in labor spontaneously, and there is a very good chances that she will deliver. Okay, but some concerns are always there, like tear. In her case, since she is primigravida with big baby, the chances of tear is very high. That is 6 out of 100. 1 out of 5 may land up in emergency section due to various reasons. Sometimes some concerns with the progress of labor, some concerns with the baby's heartbeat. But successful vaginal birth makes future births very easy and least possible complications for both. Very nicely, you had started some important points about the C-section. Okay, so you had actually started on a positive note how the cesarean section will be. Okay, so here you can just check her knowledge also. What does she knew about the cesarean section, and then from there, okay. So here, from here we will go. So her chances of occurring tears are less, that is 6 out of 100. Preventable by that OAC care bundle plan like perineal massage, episiotomy, and warm compression and examination post delivery. It's very less. Okay, the chances are very less, and the healing will also be very good. Prolonged labor only most of the time associated with adverse baby outcome like stillbirths, bleeding in brain, and ICU admission. For that, we can definitely monitor the baby. We can vigilantly plot a labor graph of this baby. Adequate pain relief will be given to her. Any deviation, yes, at that time we can act appropriately and take a it means a timely decision. Okay, take a timely decision. Then, as cesarean section is a surgery, involves cutting up of tummy and womb, carries the risk of anesthesia, injury to surrounding structure, bleeding, bowel. So there is a risk infection. You may not bond with your baby early. You may not get discharged early. You may not be feeding your baby early because of the pain associated with this section. The future risk will be repeat cesarean section, adherent placenta. If adherent placenta bleeds a lot in subsequent pregnancy, a need for hysterectomy, prolonged stay and bonding and all those things we had mentioned. On the other hand, vaginal delivery is more natural way of birthing with the least possible complications. Safe bonding, early, you can early go home early, and early recovery is very important in these cases. Some concerns are there always, that is the fear of tear, requiring a emergency cesarean section. No one can deny, yes, there is a risk of repeats requiring emergency cesarean section, but successful vaginal birth makes future birth very easy because her case is absolute low risk case, so her risk of complication is very low, and which are preventable or manageable. Okay, these are preventable, manageable to a certain extent. So here we can just give offer her, yes, not, you do not need to take a decision right now. You can go home, discuss with your partner, come up with your ideas and consult believe. The next day, next week, you, if you are not happy, satisfied, we can discuss with my consultant also. Till that time, just keep a watch on your baby's kick count, and the next appointment will be with the consultant. Okay, so this is basically a positive affirmative counseling which you need to do in cases where patient is willing to undergo the cesarean section. So here actually I should have not given you this history very positive in the beginning. I should have just told you that I just wanted cesarean section, then that why is very important, why you want to have a cesarean section, then attempts to understand. So somewhere somehow you have to definitely uh, emphasize and definitely respect their autonomy. Okay, attempts to understand the logic behind the decision, able to bring out psychological impact. Okay, if she doesn't accept, then you have to offer her counseling. Okay, counseling by the consultant and psychological counseling also, because that is a trauma which is there in her mind. For her friend's experience, you can offer her sympathy, empathy, understanding her situation, relevant information, social history, support after delivery, and plan for future deliveries. This is only important information gathering. Communication with patient and families, introduce self-role, share PIL of cesarean section, pros and cons of cesarean section, risk of bleeding, risk of surgery, anesthesia risk, placenta previa in subsequent pregnancies, risk of need for hysterectomy, reduce fertility. All those they had mentioned. I am not going to say that it reduces the fertility, adhesions, chronic pelvic pain, prolonged recovery and need for additional support at home. Yes, do agree. May not be able to go back to work weekly. Yes, I do agree. Early recovery, no guarantee that may not end up with an emergency cesarean section. No guarantee that will not have an perineal tear. Increased risk of bladder complications and long-term genital prolapse. This you can explain her, or you can just tell her that, okay, yeah, we do have see some patients. Communication, consultant, community care midwife, because you have to document her care, counseling, and anesthesia reference. Exclude known allergies, screen for MRSA because we are not accepting. So this is also, I am not taking it as a proper patient safety point. Risk of cesarean deliveries, non-directional counseling, associated neonatal complications. Okay, that we need to describe. No difference between elective cesarean section and vaginal birth in terms of benefit versus risk. Familiar with the complication of cesarean section. Use a leaflet from RCOG and other sources for the timely elective LSS. So if at all elective LSS will be offered to her, it will be at 39 weeks of gestation. You just need to tell her. Okay, anybody's having any question? Anybody? Effective counseling. We will discuss effective counseling some other time. Definitely, okay. So how you have to effectively counseling so that the patient at least will listen to you, and she will not go angrily, or she will not be going unsatisfied that, oh, doctor has not explained me anything about this. Okay. So we will discuss effective counseling. This is simple counseling task. You do not need to go into the details of examination, too irrelevant question, too irrelevant history. Okay. But overall, Dr. Reshma, you have done a good job. I will not say that you have totally dissatisfied me. It's just a few more sentences and I would have had been convinced. That's it. Nothing to worry about that. Okay. Anybody is having any questions? Shall I end the recording?